Over 70. Well, good morning, everyone. Thank you so much for joining us today for a very special Wisconsin Cancer Collaborative monthly networking webinar. We are so pleased today to be able to partner with Share the Care and provide information on COVID-19, cancer screenings, care, and the impact on our tribal communities. So thank you all for joining us today. We are so glad to have you here. I am Beth Brunner. I am with the Wisconsin Cancer Collaborative. And I just, before we get started, wanted to provide just a little background if you're new to our collaborative, that we are formally the Wisconsin Cancer Collaborative and the Wisconsin Cancer Council. So if those are familiar names to you, we are just joined under one name. And what we are is over 140 organizations that work together to reduce the burden of cancer in Wisconsin. And we really work to help our members in the community with tools, support, and knowledge in order to build healthier communities. And what you can see here is one of our tools we have is our Wisconsin Cancer Plan 2020-2030, which is really a guide on how we can all work together to really reduce that burden of cancer for everyone in the community. A partner in today that I want to make sure that we acknowledge is our Wisconsin Health Disparities Initiative. So the Wisconsin Health Disparities Initiative is in our UW Carbone Cancer Center. And as you can see here, they really work towards bringing together the community, researchers, individuals, and clinicians for the health of everyone who faces a greater cancer risk. So especially Hannah Foley, thank you so much for your partnership today and helping both Share the Care and the Wisconsin Cancer Collaborative come together today. So just a brief agenda on what we're going to walk through today is that we are just going to provide a welcome and a little background on Share the Care. We are going to have, as you can see, information given on COVID-19 and cancers that impact the community. We're also going to have some giveaways. So for those that have attended Share the Cares in person, you know that that is like one of the great parts of it is that there's just really some fun opportunities to get some little prizes along the way. So we didn't want to miss that part of our Share the Care experience. So Janelle Elza is going to help us with a virtual spin to win giveaway. And then we're going to close out with information about just our urban communities and health and wellness. And then we're going to, we didn't want to lose in a virtual environment the special connection we have, remembering those that have been diagnosed with cancer and those that we might have lost to cancer. So what we're asking today is that if you could send me, so Beth Brunner, in the chat, if you would like any names added to our virtual wall of in memory and in honor of at the end of our presentation today. So for those that might not be as familiar with Zoom, if you just go into the chat, there's a option where you can choose a name and you can choose my name, Beth Brunner. If you accidentally send it to all, that's fine too, I'll grab them, but just let us know in honor or in memory and then give me the names that you'd like. And we'd really love to remember and honor those individuals at the end of today. So one thing I would like to just do is I know that we had a partner, Robin, that was going to join us today, but has a lot of things going on in the clinic. So I just wanted to see, Robin, were you able? Robin, wonderful.
I'm sorry. It's called Dana because that's our medical director.
Perfect. Robin, what I'd like to do is thank you and the team and Carol Cameron and everybody for today, and I will turn it over to you.
Okay, well, bonjour everybody. Robin Careful, Aishna Cause Swaganin, Duchiba, Basic, Niniwag, Dave and Alice Careful. Ogitchida, Moskiki, Wakaigan, Peter Christian Health Center. So I'll say good morning to all of you. I see some of you are on. I see my good friend Rick Strickland eating a sandwich or something like that, but our longtime friend, I see another good friends, Carol Cameron, uh, different ones. I see Dr. Ignace as well. I see our good friend, Annie Waka down there, and she's not got her camera on. Then I see our fellow colleagues up in Bad River, or Red Cliff, I'm sorry. But anyways, I want to say good morning, welcome all of you. Last time we gathered in person Share the Care conference was back in Milwaukee. And I was asked by our local Milwaukee group at the time to come and help put together, be like an arena director that we have many times as working with powwows and other celebrations. Currently, right now, I'm the health director at the Peter Christian Health Center, which is one of the 11 tribal programs in the state of Wisconsin. We also have our good family partners in the Darrell L. Ignace, our urban program down in Milwaukee. So I'm glad to represent and help us introduce our Share the Care conference, the virtual care conference. So as I mentioned, that 2019, we had a real nice celebration. The Share the Care has been going back and forth between Oneida, Milwaukee was the 19, and some of our other communities have hosted that particular good conference. And we had a lot of our community members that have come and attended that. So that said, I wanted to say that I appreciate being involved. This is my second time of managing a tribal health center. And so it's been a good, kind of like what goes around comes around. In my broken Ojibwe, I mentioned my dad, David Garnet Careful, as World War II Marine Corps, and my mother, Alice Elizabeth Redwing Carriofel. She was a Navy vet World War II as well. And so I have a chance, just like Dr. Ignace. We have both professional and personal legacies to uphold. And so I was asked to help participate. And my dad was one of the first people hired by the Indian Health Service back in the 1960s, because the Indian Health was created in 1955, and the Indian Sanitation Facilities Appropriation Act in 1959 was one of the beginning points of where we are today. So why we all have running water, flush toilets, public health programs, clinics, dental programs, mental behavioral and cancer awareness programs. These are all related to some of the early work that my father helped bring to our communities in Minnesota, Wisconsin, and Michigan. So he is literally involved in every Indian household in those three states. He worked for 25 years, got 4 years out in the Marine Corps. He was a dedicated veteran, dedicated community member, dedicated father and grandfather, as well as my mom, Alice Redding. She was a full-blood Sioux Indian from Flanders, South Dakota. And being in the Navy, she lost her mom at 16, joined the Navy. It was still World War II. She became a pharmacist mate, third class at the U.S. Navy down at Bronx Naval Hospital, welcoming back all those poor soldiers that were succumbed to the European theater. So again, that is some of my personal and professional legacy uphold. I'm sure Dr. Ignace will share more. I've worked with his mom for many years. We were both like to be considered champions for health people, for American Indian people in our great state here, as well as across the nation. So I wanted to say good morning to you. I'm sitting in the Peter Christian Health Center. This Zoom kind of stuff is kind of new, but it's an interesting way how we can get this going. So I want to say welcome to that. So last thing I want to do is just say is we still forget, we can't forget our ways. So I'm gonna just say a few words, bring us all in the right frame of mind. So Gitimanadu Wakantanka Tukashila. We appreciate for all those things that you give us every day on a daily basis. We appreciate that all these men and women are gathered here today to come together, bring our minds and our hearts and our focus on some of the important issues that are await our everyday for our communities, whether it's on the reservation, whether it's in our homes, whether it's out in our farm or our urban communities. These medical situations affect us every day on a daily basis. So we ask for your blessing. We ask that our sunshine is outside today, so our Mother Earth is being warmed and guided in a good way. And we hopefully have some good dialogue today. And although it's technology, we're glad to see that we see many of you today, and so that we look forward to for your blessing to say miigwech, padamia, to all those things like that. So I just wanted to keep that in mind. So I wanted to, defer back to some introductions to some of the key people. So I'll defer to Beth and Carol and some of the other ones on the Share the Care planning team. So if you want to just introduce yourself, go ahead. Hello?
Well,
Don't
I
all
would be
speak up
happy.
at once.
No, I would be happy to jump in. So thank you so much, Robin. The other members that are here today is we have Janelle Elza. So Janelle.
Hi.
We have Carol Cameron. I believe Hannah Foley's on the line.
Yep.
And we have Alex Peters, or Alex Faust now, who's helping us out today as well.
All right. Anybody else? Okay. So what we're going to do is we have about an hour and a half, but what we're going to do is I'm going to change the agenda a little bit here in the sense that do you guys want me to talk about my presentation now? If you want to put the slides up, so we'll go from there to maintain our agenda here. So what I wanted to share is up in the right upper left-hand corner is for all those folks that I don't recognize, or some of the ones that we're looking to meet today. So our Bemidji area of the Indian Health Service, in that upper right slide there that you can see, encompasses 3 states. The Indian Health Services is an agency under DHHS, and they take the country and they split into 12 geographical regions. And Bemidji area was created probably around the 60s, and when some other areas were defined, but we were originally part of Aberdeen. And then in the 60s, Bemidji was picked as a kind of a focal center. And so in the Bemidji area, we have 3 federal service units, meaning that they're federal employees. Their program is administered and directed by the Indian Health Service. And then in the other programs that we have are tribal operated programs that are in Michigan, Minnesota, and Wisconsin. And in Wisconsin, we have 11 of them. Some are very small, or are small, but really focused in delivering. We have our Red Cliff relative to the north, where we see our partners in crime there. I don't know if my good buddy Mardella Gustafson is up there, but give her a poke in her midstory anyway. She deserves it. She used to terrorize me during grade school and high school. So I wanted to say, recognize the Red Cliff. We have our people and our folks Ojibwe relatives in Bad River or Odana. We have also our relatives in Lakota or Hayward. We have relatives in St. Croix over there in Amory, Wisconsin. We also have our Ojibwe relatives in Sokagon or Mo Lake over by Crandon. And we also have our relative Ojibwe here in Lac du Flambeau. We also have our kind of linguistically, but we have our relatives to the east up here in Lac du Flambeau to the Forest County Potawatomi. We have our Oneida relatives down in Green Bay, Oneida area. The Stockbridge Mohicanut over in Bowler. We have our good friends, the Menominee from over there in Keshena, Wisconsin, north of Shawano. We have our whole chunk relatives down in Black River Falls, Nakusa, Wittenberg, and other areas. And we have, I can't forget, our good family members, because we got many Indians living in the Milwaukee area, which I also used to be a part of that and continue to remain a part of that community and support our good relatives at the Ignace Indian Health Program. So again, you see all the different tribes, we all have something available, something to help bring healthcare. And whether it might be public health, might be primary care, or might be specialty care like oncology or things like that, where we always like to think that our programs we focus on our current problems. We focus on our efforts to look at things in the future. And these are some of this 6-letter word that we're focusing on has devastated my family and has seriously impacted many of our other family members and friends. So you see the Bemidji area, again, goes to that many areas across the nation, and Bemidji was highlighted. Next slide, please. Okay, so again, these next 2 slides are some of the different programs available at various entities, and these are the ones located at, I believe, I gotta put my glasses on here, in Wisconsin in our urban program. So you see Dr. Ignace and under his guidance is one of our 4 programs that serve our family members in many of these different areas in Detroit, Chicago, Milwaukee, and Minneapolis. Next slide, please. So what I wanted to kind of say here a little bit is we talk about what's been going on, and we hear these modern terms called generational or historical trauma. So I tried to develop a slide here. Up in the upper left hand is that first circle. You see the little brown, it's supposed to represent a little brown face. So I apologize for the artwork, but I tried to make a difference. So we had a lot of good things in our life back in the, say, pre-1494. So again, we had these things that were we had good ways of life. We depended on each other. We had our clan system. We were one in nature, one with nature. So again, many of these things that our ways of life is impacted by these various good way elements of life. So we had our culture, we had our customs, everything was good. So that represents the smiley face. Going to the next, our second generation, because natives, we talk about 7th generation. You hear that in many different tribal explanations. So the second generation, let's just say back from the beginning of our country, 1776 through the 1870s. And I picked the 70s because, again, that's when healthcare for Indians were namely ignored or didn't have any connection to our country as we now know it. So there was a lot of cultural genocide. There was loss of language, religion, culture. There was abuse, death, all these things that hindered our people on a daily basis. So again, that was some time to be brought into our affected our life and our ability to provide what we now call Western medicine. So then in the third generation, kind of going clockwise, we see a little downturn of the smile. So in the early 1900s, and as I was doing this, I mentioned that during this time, our healthcare was designed or delivered by the War Department, because we had a lot of our community members had to live around the ports to survive. They were being forced off the reservation. So they had all these new settlers, these new soldiers coming into their communities, not having their natural antibodies to fight these various diseases. So our communities were ravaged by these things. Then in I wanted to put a picture of my grandparents, because my grandparents, William Henry Careful was from LCO, and Alice Bamasanoque was from here in Lac du Flambeau, and they were born in 1873 and 1887. And so there's been always a lot of policy, federal policy, that has shaped our healthcare. So I mentioned to the right in the little blue box, World War I, IRA. That stands for the Indian Reorganization Act of 1934, where the government said, you know what, your tribes are very disjointed, you don't have a lot of good infrastructure, and we're going to give you a model government to follow. So many of the tribes in Wisconsin, Minnesota, was across the nation, their community was changed with this type of federal policy. Then in World War, that happened in 1934, but in 1924 was the first time that natives were considered citizens. So again, then I mentioned about World War II. We had many American Indian, Alaska Natives take the oath, both in World War I, but a lot in World War II. And that's where I wanted to put a picture of my parents in their military uniform. But again, a lot of these things, so when these people went away and they came back and they saw the world from a different perspective, and they come back to the reservation. So then in the fourth circle going down, we call the fourth generation. So this is during the 50s, and through the 70s, I got it listed. So back in the 50s, think about it. We got our veterans coming home from war. Well, there's nothing here for you. There's nothing here. We need to get you some work. So there was a period of relocation and termination. And that affected many of our communities across the nation, especially in Wisconsin. So you had a lot of Ojibwe, a lot of Menominee, a lot of Ho-Chunk, a lot of Potawatomis, Oneidas, Stockbridge, come to Milwaukee, come to Chicago, come to Denver, places like that. And they were promised a better way of life. So you might have somebody living on the north side, and they had to go work at Petracutty on the south side. And that promise of, if you can take an urban program and make them come back, live on the res, they'd have a difficult time. But and try to apply that same concept of saying, coming from the reservation and going into the urban setting was very challenging. But our Native people are very resilient, very good at adapting. So we were able to succeed, and we still have many of our family members living in many of these urban settings, but they are still family. They are tribal people. They are people we need to pay attention to. So again, some of the excellent work that Dr. Ignaz's father and some of the local Milwaukee people, as well as his mother, Georgiana, and they were very instrumental of why we have excellent healthcare happening in the city of Milwaukee, as well as some of the other places. So again, even this termination policy, so our good friend Annie Egan, some of her family members were involved in some of when the termination came from the Menominees, where they took away their so-called reservation status, and they were forced to become the 72nd county. And so again, they have a good, strong history, and they really embrace it, and in their schools, in their health center, and a lot of the things that they continue to do. So again, relocation, loss of identity. Then you had the Korean War. Again, many Native American men and women rose to the occasion. And we all know about the 70s, the Vietnam. Some of our parents, some of our aunts and uncles were a part of that. So we see a kind of not so good happy face. So then we go up to the 5th generation. So I use the date of 1975 because that was probably set the stage of federal policy that was called the Indian Self-Determination Education Assistance Act, that gave us the opportunity that the government realized we can't decide what's good for Manam. We can't decide what's good for the Milwaukee people. We can't decide what's good for Lac du Flambeau or other places. So we're going to create this law that allowed resources to come, and let's allow those community members, those tribal leaders, those program people to go and design the program. And I write to the 90s because again, we're in the middle of implementation. We're maximized of the Indian Self-Determination Education Assistance Act. So under those laws, we're able to enjoy some things that are not enjoyed by any other population in the entire United States. Title 25 of CFR, Code of Federal Regs, says Indians. There's not another title that says any other Hispanics, Blacks, Asian American, German, Polish. It says Indians. So our healthcare is designed, or it comes from not a color of my skin, but our legal status as tribal communities. So then in the 90s and up until the 2010, we've evolved our education system. We evolved our healthcare programs, and we're continuing to do that. So again, we're getting better. And then, so the middle circle is the 7th generation. So that's the idea of why we're here today, is saying how we can bring our minds together, how we can use the attributes of what we learned, what is there available to us, how we can remodel those things to make an impact upon every one of our communities. So when I had a fortunate opportunity to have a little grandson, we had a picture of 5 generations. It was the grandson, the mom, it was my daughter, my ex-wife or my wife, the mother of my daughters, her mother, great-grandma, and great-grandma. So 5 generations, not many people can say that. But if you are, that's great. But we got to focus on for the next generation. And I think that's why the professional and personal legacy of people like Annie, like Carol, like Dr. Ignace, and others, not just us 4, but it's always there. So folks, as you meet people, as you develop your program, you always go back to we always go back to where we're from. So it's, I want to just wrap up and say, I hope I help bring some insight. I'm going to defer to my other colleagues now, and we'll have some, I believe, some opportune time for some question and answers at the end of the session. So I'll stop there. So we'll go to back to our agenda. And let's go to Sarah Deidre over at the CEOX, or Southeastern Oneida Tribal Service Officer in Milwaukee. So Sarah Deidre.
Well, first, thank you, Robin. I appreciate everything you shared with us today. It is so meaningful to just know the history of Share the Care, and more meaningful is just the history and the importance of the information behind it all. So thank you so much. We actually had to shift the agenda a little bit today for Sarah's schedule because she's in the clinic today. So we're actually going to move to Deborah Black.
Okay.
So Deborah.
Yes, good morning. Thank you for having me. Have I been given the host capability to share my screen? Okay.
Yes, you have. So you should be able to go ahead and share your slides now.
Okay, wonderful. Let's see here. All righty. Let me see if I can do this any justice. Okay, good thumbs up. All right, great. All right, well, thank you, Robin, for those wonderful words of welcome. It definitely took me back to the foundations of why we're here, why we gather, what we do, the work that we do for, who we do it for. And I just really appreciate those opening remarks. Also want to say thank you to the Cancer Collaborative for inviting me to speak today. My name is Deborah Black. I am an enrolled Sisseton Wahpeton Dakota Sioux. I'm also Seneca from the Seneca Nation of New York, and am currently serving as the Director of Behavioral Health here at the Gerald L. Ignace Indian Health Center. Just a little bit about myself. I don't want to take up a lot of time, but originally born and raised in the state of Maryland, worked for most of my years at the Indian Health Service there in the Behavioral Health Department in Rockville before moving here in 2013, where I joined Ignace and have been here ever since. So just have really enjoyed my time in Wisconsin, and the story moves on. So a little bit about, I think, what I've been asked to speak about today, and that's just a little bit about our Department of Behavioral Health here at Ignace, just giving an overview of services, looking a little bit at the impact of COVID-19 on our mental health services and how that changed the landscape of what we do. And then just looking at specialty care services, especially with the topic of Share the Care, which is cancer care. So the Department of Behavioral Health is located in the All Nations Wellness Center. We provide therapy and counseling services, culturally based prevention and outreach programs, psychiatric medication services, and we also provide care coordination services for patients with chronic primary care and psychiatric conditions. Our therapy services are offered now via telehealth, and we have just gone back to face-to-face appointments, but are offered through, a variety of modalities. We have about 7 clinicians on staff that provide psychotherapy, as well as a psychiatric advanced practice nurse who provides medication services, as well as a clinical testing psychologist for developmental testing and any other related testing needs. This is a brief overview of just some of the major or the common mental health and substance use disorder issues that we see in the department. Major depression, I'm sure it doesn't look a lot different from many other health centers. Bipolar disorder, attention deficit hyperactivity disorder, post-traumatic stress, complex trauma, acute domestic violence, and sexual assault, along with individuals who have chronic or lifetime histories of violence, and those who present with an adjustment to chronic illness and chronic pain. These are some of our logos that have been wonderfully developed by our marketing and communications director. I'm so thrilled because I'm horrible at technology. So to see how these have evolved is like night and day. These are our 4 main culturally based prevention programs in the department as of today. We house our Warriors of Tradition Culture program, our Youth Empowerment program, our Native Connections MKE program, and our Circles of Strength domestic violence, sexual assault, and human trafficking program. Just to give a little bit about each of those, our Circles of Strength program is a program that's pretty robust and comprehensive in the array of services that it provides. We employ a full-time domestic violence and sexual assault advocate who is available office hours, working on a 24/7, as we do see the need for that, as well as we have quite a few therapists on staff that specialize in treating domestic violence and sexual assault. Currently are building the capacity with the University of Wisconsin-Milwaukee Department of Nursing to incorporate forensic nursing services in our medical department. That's our probably newest endeavor that we're working on to not only offer therapeutic services for the treatment of sexual assault, but to also offer the continuum of medical services in the event of a sexual assault. During COVID-19, we were very lucky to be a recipient of the VAWA Stop emergency funding for women who were at an acute risk of violence. That funding was Native specific funding, and it really helped 10 Native women in our urban community escape violence during quarantine and safer at home. This is just a picture that I love. This is pre-COVID times. The Healing Shawl Project was our trauma-based group for domestic violence and sexual assault providers. And it was a weekly therapy group. And we were, at this time, I think it was early March 2020, right before we were all ordered safer at home, and we were making healing shawls for the upcoming Red Shawl Gala. The ladies wanted to donate something to the auction that was near and dear and special to them. And with that, we got interrupted shortly thereafter. Native Connections is another program housed in our department. This program focuses on addressing suicide prevention and intervention with the most high-risk group, our 15 to 25-year-olds. In this program, we focus on reaching out to Native students on high school and college campuses, providing outreach support with the program leads of these programs at GLIC. That could look like anything from check-in calls with the youth and their families to providing small talking circles. COVID-19, those turned to Zooms. Working with colleges and universities on just how to support Native student mental health. Myself and Dr. Ignace have provided many workshops or in-service trainings to clinical counseling departments of universities within the state of Wisconsin. We welcome that, just based on spreading some information and education about working with Native students in a culturally sensitive manner. And then also just letting these schools know that Ignace is here for students who may be struggling with their mental health as a referral resource. This is just a slide that shows a host of culturally based services that are incorporated into all of our community-based programmings. So all of these were very pre-COVID. We had to get a little bit creative looking at how to do them at the beginning of COVID-19 and be as creative as we could, as I know many of us were faced with. So enter COVID-19. Our behavioral health staff definitely recognized the need to move services to telehealth, as did the whole health center. and also recognize how the clients were responding to quarantine with safer from home orders. And what our observations were was just, and it pretty much was, global, was that our clients were having very acute reactions to not only, number one, not being able to come in for their appointments, not being able to engage in their behavioral health and wellness routines, but also nervous that those would cease and stop. So a lot of high energy, a lot of uncertainty, anxiety, and fear. Ignace has been known as a walk-in place to feel welcomed for many of our most vulnerable clients pre-COVID. And when COVID began and quarantine began, no longer could you come in and grab a cup of coffee. It just wasn't advisable at that time. And so I think that's been such a hard switch and such a hard change and adjustment for some of our clients that really don't frequent a lot of places in the day. And Ignace actually was one of their stops in their days to just check in and ensure that they're okay, and we know they're okay. So causes a shift in relating and service. Definitely COVID-19 did that. It required our staff to reorient services. Excuse me, I think I went too quick. Now I don't know how to go back. Sorry. Oh, let me see here. I couldn't read my slide because there we go. Okay, so it required our behavioral health staff to reorient services with clients to really help them with examining self-care practices during quarantine. So what we really focused on in the beginning, kind of in that phase one of COVID-19, was to help them adapt to new self-care practices, given the inability to engage in any pre-COVID activities. For many of our clientele and our patients, a key piece to their wellness is presenting for a weekly behavioral health appointment. Isolation with many psychological and emotional disorders is often a huge facet of those issues. And so the encouragement always has been, hey, come to your appointment. I know you might not feel like coming in, but hey, it's really important, to try to get here, do the best you can. And now, for patient safety from COVID, they were getting opposite messages. And it really, I think, yes, kept them safe from COVID, but also had a backfire effect on the mental health and wellness and the struggles that they're experiencing. There was an increased buzz around self-care in all forms of the media. And so part of that strategy with our clientele was to kind of provide that education of focusing on ways of alleviating self-care, trying to help clients understand why self-care is important, that it assists with regulating our nervous system. It helps with modulating, a stressful environment or stressful relationships with others. And that, during this really uncertain time, that really looking at how you're changing your self-care routine could help increase your capacity to manage your daily life and to manage what you have to do and your emotions during this really uncertain time. We definitely had concerns of client safety, just maintenance and well-being. Just looking at the neurobiology of stress, and given a very stressful, uncertain global situation, the impact of stress just on daily decision-making, reasoning, keeping routine is intense. Social isolation, such as quarantining and physical distancing, definitely can be interpreted by the body as a similar fear response that many of individuals who struggle with mental health struggles experience on a daily basis. A lot of times that's what they're coming to mental health treatment for. So the fear increases when you're sensing your level of control over a situation is low, or the ability to predict what will happen is low. And so the ongoing situation just perpetuating and maybe preventing a backslide in any of the progress that some of our clients had made to date. So there were massive concerns for clients who were already in a vulnerable place before COVID-19. Our GLIC COVID-19 response strategy mobilized pretty quickly. We were able, luckily, to transition to our telehealth platforms within the first week. And I think that was really key. I realized that we are really fortunate to be able to do that. And that really helped with the continuity of our behavioral health treatment services. We realized that one of the barriers to care was that many of our population that we service often struggle with either internet connectivity or even having a device where they could receive a phone call or connect. So we implemented an on-site telehealth room that we still have in operation today for patients with little to no connectivity, and that really did increase their access to their treatment care professional. We also worked with our Director of Marketing and Communications on a really strong communications marketing plan for behavioral health and our culture-based prevention programming. The culture-based programming is where a lot of the community, where we receive a lot of the community during non-COVID times. And it was, how are we going to let the community know that we are still here and that we're still available, and communications was key. So here's one of the infographics that was, I think, first developed as COVID-19 started, and it really focused on that self-care issue, just trying to get out to the Native community. Hey, these are the really important things right now. Like, just let's focus on self-care. You know, let's abide by our by the guidance that we're receiving from the CDC. So just really getting these messages out as quickly as we could. Figured I'd use our youth empowerment program, which is our suicide and substance abuse prevention program for youth 7 to 24 years of age. And we have an on-site youth center that provides after-school services during non-COVID times. That was quite a transition as well. So just trying to figure out how to keep families engaged the best we could with cultural resources and activities and expressive arts and all the things that the kids would come to the youth center for. Once again, just another example of how we transitioned into a virtual world. Just really love kind of this is a complete Zoom. It's Ignace Youth Center gone Zoom. This is how it would look if they were in person, and how it looks just now on a Zoom hangout. Love this 6 feet trick or treat. Once again, going into COVID times, really trying to spread that message to families, but keep some normalcy. So lastly, I wanted to just spend a minute or two talking about our care coordination services. So our care coordination program here in the Behavioral Health Department focuses on coordinating care for patients with chronic health conditions and mental health struggles. As we all are familiar on the call today, that the impact of cancer is tremendous and can be very shocking. There are many struggles that come along with receiving a diagnosis, as well as going through the journey of treatment and survivorship. Along those ways, there may be an increase in mental health and psychosocial struggles. And very commonly, research is showing that there is an increase in adjustment struggles or disorders, which is, adjusting to a cancer diagnosis and or to treatment. An increase in depression or depressive disorders, often related to a decrease in daily functioning, or with pain and performance, the effects of the life-changing effects of a diagnosis. Anxiety and trauma-related stress, the uncertainty of dealing with a chronic diagnosis, and then we're looking at acute stress versus longer PTSD. On this slide are just some other issues that can come along with adapting and the impact that cancer can have on the mental, social, and emotional health, from somatic and body-related disorders, just experiencing and adapting to a different connection with the body and the symptoms that are experienced. Neurocognitive disorders ranging from mild to severe due to prognosis or treatment. Sexual disorders and dysfunctions, changes in body image, loss of sexual function, loss of reproduction, and many of these can co-occur with each other. They don't happen singularly. And then just other psychosocial issues and ancillary struggles that pop up, lower family and social support, financial burden, a loss of independence, a loss of meaning and hope, an increase in suicidal ideation. Many of these impacts are very shocking and devastating. Here in the department, when we do look at chronic illness and behavioral health, we do look at it from a culturally integrated perspective. But when we do look at chronic care and behavioral health, we look at providing education. We look at providing coping and psychological support. We look at providing specific counseling and therapy interventions as indicated. We look at the client's outside world and how we can help that client with any rehabilitation. There's, of course, psychopharmacological interventions that are available if that is how the patient so chooses to receive treatment. And then also there is care coordination between our multidisciplinary teams and specialists. This last slide just tells a little bit about that care coordination. It is a program that I don't think we could operate without. Our care coordination program provides individual assistance to patients that often need extra assistance. So what that often looks like is coordinating appointments for medical therapy and psychiatric medication needs, monitoring calls to just check in on patients and their mental and emotional and social supports, monitoring a patient's treatment compliance or troubleshooting barriers that are interfering with treatment, establishing care plans with patients to assist with chronic care management, and then also assists with any case management needs that patients may be experiencing. So housing insecurity, food insecurity, obtaining access to durable medical equipment, etc. So just a brief overview of our department services. I am going to transition and stop sharing my slide deck and just want to say thank you for having me today to speak to you a little bit about our services.
Thank you so much, Deborah. We really appreciate it. Amazing information. And now I'm so pleased to be able to introduce Dr. Lyle Ignace. So Dr. Ignace.
Yes.
We are going to give you the host privileges so you can share your screen.
Okay. Let me. All right, give me a second, everyone.
While you do that, I can do a brief introduction on Dr. Ignace. For those that don't know Dr. Ignace, he is the CEO of the Gerald L. Ignace Indian Health Center in Milwaukee, Wisconsin. He is also a member of the Menominee Indian Tribe of Wisconsin. It looks like we're set. Perfect. Dr. Ignace.
Thank you, and thank you for having me come back. This is, I did present back in 2019, and so this is a bit of a continuation and update as to cancer in Indian country. And what I find really important is a lot of what I will be presenting today is going to help kind of guide public health approach, especially as we come out of COVID. As people may be aware, I do a native town hall on COVID. I've done weekly kind of seminars on COVID for the past 16 months. And so I do present a lot of updated information on COVID and the impact on Indian country. And so it's nice to kind of shift gears here and get back into discussing about medicine. And I think it's really important because the impact of the pandemic has affected us beyond just the COVID and the infection and the devastation that it has caused, but there are consequences to the effect of COVID, and it has directly impacted how we provide healthcare today. And so there's going to be a lot of information, and so I'll try to go through this as quickly but as informative as possible. And one of the things I found was that it's really hard to find data on Native populations. I was successful in at least identifying one, and I'll go through that. And so I'll be citing quite a few references to cancer in Indian country. But here I wanted to give some background because it just doesn't affect Native country, but also the entire United States. And so, as you can see here, the American Cancer Society estimates that 600,000 people had died from cancer in 2020. And that's beyond just the numbers that we have with COVID. So you can estimate that's a lot of individuals. And we all probably know someone, family, friends, that has been impacted by cancer. So obviously the early detection and even the prevention provides the best option for identifying and even making sure that we stay as healthy as we possibly can. Now, the National Cancer Institute, NCI, estimates almost 10,000 excess deaths from breast and colorectal cancers alone due to the pandemic-related delays in cancer screens and treatment. So this is pretty interesting, and it has a direct impact on every health service within the Indian Health Service, whether it be federal, tribal, or urban program. And I know it will affect our community here in the state of Wisconsin. So around the country, again, the American Cancer Society estimates that more than 1/3 of adults failed to receive the recommended cancer screens during the pandemic. And that's really significant. About 43% of patients may have missed their routine preventative appointments due to COVID, or at least concerns about transmission of COVID. 35% of adults had cancer screenings scheduled during the pandemic and missed it. So this is really, really significant. I'm of that age now where I need to, at least personally, make sure that I maintain my preventive screenings. And I consider myself a little bit fortunate. Everything was normal, but I got it done right before COVID started impacting. So I can understand the fear and concern of doing screenings in light of the pandemic, and yeah, people just didn't want to be in the hospital because we didn't know much. So another estimation, so on an annual basis, we do a lot of screenings throughout our entire health system. 22 million cancer screens were canceled or missed between March and June of 2020. Now, I'm sure everyone can remember back in March. I remember March 12th as kind of being the day where everything started shutting down. Hospitals started shutting down. They stopped doing elective procedures, including cancer screening. So there was this whole time frame, March, April, May, June, 4 months, where everything just kind of grinded to a halt. All the healthcare services were geared towards just the acute management and hospitalization and treatments for individuals with COVID. And so you can, from a health scheduling and operating point of view, 4 months of no screenings really not done in the country. You can imagine, if you've ever had to get a screening scheduled, they will schedule you out 3 months, 4 months, 5 months out. And now they had to cancel all of these. And so there's a backlog, and then there's become even a more delay. Even when hospitals started opening up screenings, there still wasn't a huge influx of individuals, saying, hey, I want my screening done. That was a slow process to create as well. So there were a lot of missed screenings in the year 2020. So what does that mean in terms of what types of screens were missed? Well, breast cancer screens were down 85%. Colorectal cancer is down 75%. Prostate cancer 74%. Lung cancer screens down by 56%. So this is looking at it from a national perspective. Now, what would be interesting is how does that impact native country? And that's really huge, given that we know that our screening rates are not as high as the national average. You can see all of these screenings have dramatically decreased. And so when we start kind of looking at what was the impact, and it's going to be, the information has not fully come out, but there's estimations and projections as to what this may look like. These are rates that were
What we gotta
done.
do is leave this meeting and turn this.
These were mammogram data rates for women ages 50 to 74 who had mammograms in the past 2 years in 2018. So this was prior to the pandemic. And so we see African Americans 74%, white 73%, Hispanic 71%. natives, 66%. So obviously that is a lower rate than other races and ethnicities. And when we look at looking at 85% of mammograms done were down, the screenings were down, we can see that perhaps estimated that maybe 10% of women ages 50 to 74 in native country actually had a mammogram done. And you can see how that goes out to other races and ethnicities. So this is really huge. And we're talking about the early detection of cancers, and screenings are our principal ways of doing this. This is going to impact our communities. And now that, screenings are now starting to kind of ramp up, we are able to now kind of pick up these early detections now. But again, it's a delayed response, and that's very concerning from a provider standpoint, because we know the earlier you detect a cancer, the better off. Rick, you look like you have a question. No, okay. All right. So I want to kind of bring this back to a national perspective, from a Native national perspective. Now, the United States Cancer Statistics is looking at IHS, coordinating with IHS and all the registries. And they're kind of reshaping. I know Robin talked about IHS and all of the regions that make up the Indian health system. Well, this U.S. Cancer Statistics Organization is kind of reshaping how data is gathered. So instead of looking at 12 areas, now they're looking at 6 areas. And so as I go through this, I'm going to be referencing areas that are very different to how we think in IHS terms, but how the national cancer societies look at regions, especially in native countries. So as you can see, Northern Plains. So normally this would just, if we're talking about, let's say, Bemidji in IHS terms, that would be Michigan, Wisconsin, and Minnesota. Well, here we're looking at additional states: Indiana, Iowa, Ohio, Nebraska. We're looking at North and South Dakota, Wyoming, and Montana. We are now grouped into this Northern Plains. And then you can see other aspects and how the country is distributed and how natives are batched together in these new regions. Now, from the CDC has information. And so what I wanted to give this is kind of give a perspective of all types of cancers that are being gathered, information that is gathered. So there is a coordination with the Indian Health Service and the cancer registries. So if you look at the Northern Plains, so that's here kind of mid to the right of center, we see in blue, the native population has a rate of 557 cases per 100,000. Now, in order to look at cancer data and information, you want to compare oranges, apples and apples, and oranges to oranges. So, and the way to do that is you go by rates of types of cancers, or just a rate of a measure. That way you level the playing field and you can look at it, everything as being same. So in the Northern Plains, all types of cancer, 557 per 100,000 for natives. For non-Hispanic whites, 450. So as you start looking at how this all lays out, we can see that the Northern Plains, where we are here in Wisconsin, we see that we have the second highest rate of all types of cancers, okay, and only second to the Southern Plains. So this is significant because this is before the pandemic. And my concern is, what is this going to look like moving out of the pandemic when we know there's been delays? So looking more specifically at the Northern Plains in the United States, new cancers, men and women, and again, looking at rates. This is the time frame of 2014 to 2018. So on the left-hand side is the native population. So I want to kind of highlight 4 very specifics. You see red dots. So lung and bronchial cancers, colorectal cancers, kidney and renal cancers, and liver and intrahepatic biliary system cancers. These are probably the highest cancers, at least in the Northern Plains, in this time frame. When we look at comparing this to the non-Hispanic white population, we see in comparison that these rates are dramatically lower. So again, these are high level concerns and risks for cancers in the native population in the Northern Plains. So that probably involves a lot of us and our families that reside in this area. I know this slide is very dense, but I wanted to highlight and bring it up because this was probably the most comprehensive data set that I've actually seen of most recent time. So here at the bottom, the reference, I referenced the source. It's the incidence of and trends in the leading cancers with elevated incidence among American Indian Alaska Native populations 2012 to 2016. This was the American Journal of Epidemiology, and it was just published October 14, 2020. So this is a pretty significant evaluation of cancers. And what we know is, we know that cancers are different in different parts of the region, of the country, as well as the types of cancers, the incidence, the rates of cancers are all different. So when we talk about cancers in Native country, we know that there's very different, we know there are very different incidence rates of types of cancers and overall cancers of different regions. We know this, there's been a lot of articles published on this, but here, this study examined the trends for cancers with elevated incidences compared to non-Hispanic white population. So this looks at age-adjusted rates, and trends were calculated for cancers and rate ratios and the average annual percent change. So this of natives as well as non-Hispanic white. So on this, you'll see on the left-hand side, this is the male data set as well as the female on the right. So when you go through this, let's just go through the Northern Plains. I had mentioned lung, colorectal cancer, liver, and kidney. Those are kind of the main cancers that are seen in the Northern Plains. So as you go from left to right, you will see a AIAN AAPC, the average annual percent change of cancer. So this is looking over a period of time, looking at these types of cancers, and an elevated number, let's say liver 4.5, that's an increase of 4.5% of liver cancers during this time frame. So when we look at natives compared to non-Hispanic whites, we see that 4.5 to non-Hispanic whites at 3.8. That's a significant change. When we look at a significant difference, when we look at kidney, 2.9% to non-Hispanic whites of 2%, again, this is a significant difference. Now, a negative number actually means there was a decrease in these types of cancers. So I know this is a lot of information, but as you go through this, you can go and look at region by region by region, and you can identify what areas actually have higher rates of change, which have lower rates, and you can start looking at comparing natives to non-Hispanic whites. So pretty significant. Even when we look at the female portion of the Northern Plains, again, we see liver, we see kidney, and oral cancer. And so, oral cancer in Native women, 2.5%. Again, that's significant when you look at the non-Hispanic white population that increased 0.4. Definite differences of what's going on, and you kind of wonder why is that, and I will get to that in a minute here. So But I wanted to bring this up because this is probably one of the more informative papers that I have seen that actually outlines cancers as a whole by region, and it's really a good article. Now, this one again, it's kind of a dense read of numbers, but again, if we just focus on the Northern Plains, so this paper at least showed evidence and data that was aggregated across cancer sites all over the place, all over the country. And again, highlighting the high end cancers here, like liver, stomach, kidney, lung, colorectal cancer. We see that these elevations have occurred. And how does that extrapolate to what we expect to see every year to what we actually observe? And so when we have this observed to expected ratio, okay, this is actually identifying. So this is kind of biostatistics a little bit, but an observed to expected ratio, if the number was 1.0, that means you would at least expect to what you thought was going to happen to what you actually observed. The difference in this, okay, the higher the number above 1, tells you that things are a lot more is going on in the world than what you actually expected. So when you look at this number of excess cancers, and you see these numbers for liver 46, kidney 77, and I have underlined 567. This is the total excess cancer cases. So what this actually means is you almost have to think it inversely, intuitively. You would think this is telling you that the opportunity to potentially avoid cancer is 566. Now, I just put up a grouping of these, and when you added them all up, it actually turned out between 2012 and 2016, nearly 5,200 excess cases of cancer were diagnosed. Now, a number doesn't tell you a whole lot, but if it tells you, hey, there's cancer out there that is occurring that we're not picking up in its early form or even preventing, it helps in terms of guiding institutions thinking of how do we look at preventing these cancers, but also from a public health approach, how do we look at increasing our screening efforts, not only by state, by region, by tribe. I mean, this goes a long way. So if you have a chance, I would definitely take a look at this article because this is really informative. Now, we heard Robin talk about the Indian Health Service. So we're talking federal, tribal, urban programs within the system. The Bemidji area, okay, that's Michigan, Minnesota, and Wisconsin. So again, here I'm posting the age-adjusted rates per 100,000 of the 10 leading causes of deaths in natives compared to non-Hispanic whites. So on the far left-hand side, we see the darker bar graph here, the darker green, that is the native population, to the lighter green being the non-Hispanic white. And we see that cancer and cardiovascular disease are the #1 and #2 leading causes of death for natives in the Bemidji area. So, and when we look at comparing it to non-Hispanic whites, it's at a much higher rate. So these are important things to see, and drilling down a little bit more to here in Milwaukee, looking at the causes of mortality in the Milwaukee service area from 2010 to 2014. Here again, we see the #1 and the #2 cause, cardiovascular disease and cancer, okay? If we look at it for women, we see cardiovascular disease and cancer #1 and #2. If we look at the male causes, we see cardiovascular disease #1, diabetes #2, and then third is cancers. It's not what type of cancer, it's just all types of cancers. Now, here for men in Milwaukee, the cancers of 29 cases per 100,000 to the non-Hispanic white has a much higher rate of 84 per 100,000. Obviously, there's a difference here. And so does that necessarily mean that more males in Milwaukee are healthier? You know, I don't know if you could say that, but you can at least say the diagnosis for cancers, okay, and new cases are actually much lower here. Now, kind of broadening this effort of identifying cases. If we look at races and ethnicities in Wisconsin between 2011 to 2015, we see that heart disease is the leading cause of death for natives. We've seen that, I've demonstrated that, but cancer as being the number 2. Okay. If we look at all cancer, so on the average, 31,000 cancers were diagnosed between 09 and 13, and with a little over 11,000 cases of mortality. So if we look at mortality and incidence of cancer, all races, we see that the native population has the second highest incident rate and the second highest mortality rates of cancers here in Wisconsin. Looking a little more specific, colorectal cancer, again, natives and the African American population have the highest incidence rate, with natives having the second highest mortality rate. Breast cancer, natives are right in the middle, 108,000 per 100,000, but has the second highest mortality rate. So we see that, yes, there are cases, but it may be a reason for this higher mortality rate is the latter, not diagnosing this early, but in their later stages. Lung cancer, we know that the native population here has a high incidence of smoking. You can see that as it correlates here, natives have a high incidence of cancer of smoking, 106 per 100,000, with the highest mortality. Obviously very concerning. I'm going to skip this. These two slides talk very specifically about what types of cancer and the rates with natives compared to non-Hispanic whites. The bottom line is basically every cancer type, the ratio is higher amongst natives than non-Hispanic whites. So across the board, when comparing cancer types, very concerning. So, and I just wanted to highlight two: liver and intrahepatic duct, bile duct cancers, and kidney cancers are the highest disparities of cancers in natives compared to non-Hispanic whites. So as far as updated information, so again, the Wisconsin's cancer registry does provide information about natives. And kind of interesting, the age-adjusted incidence among natives for all cancers, we know that there's a higher rate, but there's actually been some changes that have been occurring. Again, this is pre-pandemic, so this could definitely change in a couple of years, which I suspect it will, like lung cancer. Lung cancers has decreased in men, but has actually increased in women. Okay, that seems a little odd and not very intuitive, but lung cancer in men have decreased, in women it has increased. Cervical cancer has declined from 25 to 14 cases per 100,000. However, in the last 5 years, this is still higher than the non-Hispanic white population. So very different inclination here. The incidence of breast cancer has increased in this time frame from 79 to 138. Intervals, colorectal cancer intervals. In men, the rates have decreased, while the female rates actually has decreased, but not shown to be statistically significant. So these are slides I wanted to shift, and this will go fairly quick. So these are heat maps, Wisconsin Cancer Reporting System, 2010 to 2015. Some of you may have seen this, but this is really, I was part of this group to actually show cancers of lung and breast cancer in the state of Wisconsin, but apply this to the Native population. So we have heat maps of high rates of lung cancer to lower rates in blue, and you can see the overlap of tribes, okay, throughout the state. Now, all the tribes are represented, so rather than kind of go over specifically, you can get an idea of region, of family, and your risk, not risk, the incidence of lung cancer. Looking at males to females, again, we have the heat map overlapping with the tribes, so you can see that there are high rates of cancer. At least in this particular case, you can see on the left-hand side, the male, we see that really dense red in the Ho-Chunk tribal area. That would be concerning from a public health standpoint and from a provider standpoint. I don't know what the rate of smoking is there, but obviously there is a higher incidence of lung cancer in that area. We look at the female population. We see Saucogin, we see Forest County, Potawatomi, Lac du Flambeau, and in the northern Ho-Chunk reservation, central Wisconsin, again, higher rates in the female population, very concerning. We look at breast cancer, incidence and mortality. Again, we see, there are areas of high concern, especially in Lecouleray, like the Flambeau, Menominee, and Stockbridge-Muncie. These are areas of concern that people should really focus in on. Now, we know that the American Cancer Society estimates that 45% of cancer deaths can be prevented by changing behaviors. And what would these actually be? Well, we know that tobacco use, secondhand smoke, excess body weight, insufficient physical activity, and alcohol use. These are preventable behaviors that could be modified that may help reduce your risk of cancers. So if we look at estimated percent of populations that currently smoke, this is the year 2011 to 2014, again, another heat map with overlying tribal areas, and we start seeing higher levels of smoking. Higher levels of smoking in Lac du Flambeau, Potawatomi, Chippewa, Menominee, Ho-Chunk. We know that alcohol plays a risk in cancer. Higher levels of drinking are estimated in the Bad River, Lac du Flambeau, Potawatomi. So again, I'm not trying to single out tribe. I'm trying to show you the information that is currently out there and how this actually can apply to efforts, health centers' efforts to promote behavioral changes and increase risk of cancer, and how we can mitigate these from a public health standpoint. Here we see estimated percent of population with physical activity, more than 150 minutes per week. Also estimated percent of BMIs greater than 30. So again, concerning areas in the Lac du Flambeau area as well as Potawatomi area. These are areas of concern. We know that medically underserved areas, populations here in Wisconsin, 2017, this highlights the counties, including the Milwaukee County here. So I didn't put a heat map on this, but if you overlap, I'll just name some of the areas. So we see Bayfield, so we're talking about Red Cliff, Lac du Flambeau, LCO, St. Croix, Menominee, Stockbridge, Ho-Chunk, and obviously here in Milwaukee. So these are, when we talk about access to care, we want to see where underserved areas, but where is the underserved areas of health services? So these are really important things to know, especially when you want to create public health approaches to do this. And here, populations without health care coverage and people estimations that have a personal doctor of health. So again, overlapping, you get a sense, areas, tribal areas that have low estimated health coverage and access to doctors compared to other parts of the state. So these are really important, and I think I'm going to just get in under the time here. So looking at, okay. So I talked about a lot of cancer studies. I talked about a lot of the effects of the COVID and how it has impacted screenings. There aren't any studies and articles about the impact of COVID right now in Indian country. That'll happen. It's going to come. But I at least demonstrated to show you that the delays of cancer screenings have been dramatic, and it's going to cause delays. And and we always talk about prevention and the early detection. We may be looking at identifying later stage cancers, which is going to be unfortunate, and it's going to impact Native people, not just here in Milwaukee, in Wisconsin, in Bemidji, in the Northern Plains. It's going to be the entire United States. So this is all coming. It will all happen. We just don't know how. I'm trying to put a positive spin on this, and I would like to hope that I'm wrong, but my fear is that we are going to see later stage cancers in the next year or two, and we really won't know the full impact of COVID on cancer screenings, at least for a couple of years. And so that now is getting people back. So tribal health services, federal, tribal, and urban programs really need to look at focusing in on how to get people back in, how to get people back in person, how to figure out how to coordinate, how to make these referrals in a very efficient way, in a manner to get people in, especially our Native population, back into these screenings. It's going to be important. We are trying to do as much as we can. We're getting as many people as we can back into the clinic. And so, we provide assistance. We're looking at transportation. We know that people have financial hardships, and transportation seems to be the biggest issue. And we are creating a program that will help us to get people to these screenings. So we provide gift cards. We work with the Wisconsin Well Women Program, assisting the screenings, and the Pink Charlotte with mammograms here on site. So we are trying to figure out every possible way of trying to get folks into, and football season is here. Green Bay Packers. I'm not going to talk about Rodgers, but a quote from Vince Lombardi, head coach: "The achievements of an organization, the result of the combined effort of each individual." And you can extrapolate that basically to every Native health organization, not only here in the state, but in the entire country. This is going to be a heavy lift moving forward and getting people back in the screenings. And so with that, I will turn this back over to you, Beth. Thank you.
Thank you so much, Dr. Ignace. And so powerful, because you're right. I think that is our fear in the cancer community, is that we may begin to see more late stage diagnosis. And that's where we just appreciate your efforts, and we appreciate the information you have shared today, because we know we have some work in front of us to move forward. So great quote. You can always fire up a group with a Go Pack Go and get people ready for the season. So thank you so much. I know we are running a few minutes behind, but we have another fantastic presentation. If you can stay on the line, we would love to have everybody stick around. We will be sending out an email afterwards on behalf of Share the Care with an evaluation. So if you are able to stay, please do. And if for those of you that at some point might need to drop off, just know that you are also registered after you fill out your evaluation. So we look forward to everybody staying. We have a few more items on the agenda. And what I am very pleased to do is introduce our next speaker. So Sarah, are you on the line? Are we?
Yes.
Oh, wonderful,
Yes,
Sarah. So nice to meet you.
Carol's computer, but she's covering the front desk for me, so.
Well, thank you so much. And Sarah is the center manager for the Southeastern Oneida Tribal Services. So Sarah, welcome, and I'll turn it over to you.
Thank you. All right, so I guess I don't see my presentation on my side. Oh. Okay. Well, for those that don't know me, one of my slides didn't show up. I'm Sarah Data. I am the manager of Southeastern Oneida Tribal Services here in the Milwaukee area. Carol invited me to do a presentation just as like one of the community partners. I've been with CIAT since 2014 and just recently became the manager this past May. So I'd like to thank you for welcoming me into the community. Oh, and we'll just get started here. So just a brief, Carol's helping me here. A brief history of our center here in the Milwaukee area. The Southeastern Oneida Tribal Services office started with 10 tribal members in the Southeastern area that were dedicated and really organized to get our own location and more of a satellite office for our tribal members living off reservation in the urban area. Their main purpose at that time was to connect tribal members with the programs and services that the tribe was offering in Oneida, but just extending that help to those in the urban area. Next slide. Oh. Can you, where they are. Since then, we have relocated a few times, and we're now on the near south side of Milwaukee in our new building that was renovated and remodeled, and we opened in 2015. Our office is located off of Morgan and Forest Home Avenue for those that are familiar with Milwaukee. And then with that, we just are able to, again, provide those services for our tribal members and still being a satellite office. Next slide. So today, there are just over 2,000 Oneida tribal members living in the Milwaukee area. CIATS continues to operate as a satellite office serving those members in southeastern Wisconsin, with the priority being wellness and connecting with community education and quality programs and services to our tribal members, whether it's cultural, mental health, wellness, just overall well-being in general. Our mission is strengthening those cultural connections so that we can be strong Oneida people and provide for our next generations. Our service area that we are technically providing to is the Milwaukee, Kenosha, Racine, Ozaki, and Waukesha areas. But we also have community members that come from Illinois to utilize our services as well, as it's not as far to drive all the way up towards Green Bay. Next slide, please. So currently, our current staff right now, we're very limited. I am the only employee at the time. Our previous manager took on another job within the Oneida Nation. So it was currently during COVID, it was me and Mark Paulus, which many people might be familiar with. He is no longer here. I am the manager now. I recently graduated from UW-Milwaukee with my master's in social work with an emphasis in community organization and leadership. So it's kind of just perfect timing. Prior to that, I was the community program coordinator for 3 years. In that role, we provide referral services to both whichever area our tribal member is living in, or if they qualify for programs in Oneida, and then outreach, cultural programming, and then family resources as well. We also have 2 administrative assistant positions, which are currently vacant as well due to COVID. I was actually the admin when I first started here, so I've worked at all levels of this office and know how to serve and provide for our community as best as we can. In addition to the CIAT's office, we also have 2 Oneida child support caseworkers within our office that fall under Social Services of Oneida. So we do have them here. Due to COVID, they are working remotely. So again, our office is very limited at the time, but we are still open providing services. Right now, the main service is the Oneida Pharmacy and Medication Distribution Program. This program allows tribal members to access the pharmacy in Oneida, whether they have insurance or not, and then we pick up the medications for them once a week. Again, due to COVID, a lot of our in-person services are on hold, but what we do still offer the community is access to our computer lab and just equipment. So if they need to print off anything for applications or their unemployment or any of those services that they may need, they can come in and use that. Because again, just having access to the internet or printers can sometimes be a barrier. So those are currently what we're doing at the time. Next slide, please. Prior to COVID, many of our services dealt with our community, our elders, our youth, really just getting outreach in there. So I listed some of the programs that we had prior to COVID. During this whole time and not being able to be in the community and being apart and around each other, one of the main concerns that we did notice from our community was food security. So in addition to the programs that I have listed, another program that we did start, or not start, but became a partner with was with the Hunger Task Force and Feeding America food distribution. So we were able to offer that to our tribal members and community members as well during those times in like a drive-through format. People were able to come through and pick up food. We also were able to have different grants that we offered food delivery to elders that were unable to drive or anyone that was unable to make it to our facility. Next slide. So again, due to COVID, connecting with our community has presented some barriers during this time. But prior to that, we were offering assistance with our community partners to offer and host educational programming. This was in the form of cultural, health and wellness, mental well-being, and then just community and togetherness, I guess, as well. A picture here is of our former community education specialist, and I know she was involved with Pink Shawls as well, Debbie Shako. She is still one of our volunteers here, and she does the traveling museum, which is a big request that we get from both educational organizations and outside communities that are looking to learn more about the Native community, urban Native community, and then how we're integrated within our building here now that we have a new location. Next slide. I just put some of the community partnerships that we have worked with in the past. Again, because of COVID, a lot of our things are on hold. One of the ones that I really enjoyed within our own building was with First Nations Studies. We would have the book club and college access program that would be within our building here weekly. So being able to see the kids and just getting them engaged in all different kinds of things. It was always nice seeing them around. A few other ones are the Indian Community School, the Her Wellness Institute, the Ignice Indian Health Center. We partner with them for the, we help with the toy, we call it the Giving Tree. I'm not sure what the actual name of the program is, but our community really loves buying the gifts for the kids and helping with that too. So those are some of the programs that we've helped with in the past, but definitely looking forward to being a part of once we're able to get together again. Next slide. So just relating it back to the navigating healthcare, CIATS has been a
May I
part.
interrupt for a second?
Oh.
I'm so sorry, Carol.
Sure.
I saw the Ascension Columbia St. Mary's emblem there, as long as
Yep.
a Wisconsin Wild Woman.
Mhm.
Just to let everybody know, my name is Claudia, and I represent Ascension Columbia St. Mary's Community Services Department, and I work in collaboration with CIATS, Pink Shawls, Carol, and we organize a couple of mammography events per year, and we've been ongoing as of April, so we're good to go. So don't forget, we're still running together. Okay.
Yep, that's on this slide actually.
Ah, well, I'm glad I freshened it up for you guys. I'm sorry, but I just wanted to make sure that everybody knows that we're still providing the mammography services to the clientele of CIATS and Pink Shawls and all that. Thank you. Sorry.
So as I was saying, CIATS has been a part of the Pink Shawl Initiative since 2007. During that time, they host 2 events a year to get the community involved and to make sure women are connecting with resources, screenings, and support that they need for educational programming, and then also for breast healthcare. So the upcoming, we had one, I think it was in April. The next one is scheduled for October 16th, and that one's taking place here at CIATS from 8 a.m. to 12:30 p.m. that day. Next slide, please. And just to wrap it up, because it's kind of short and sweet, I just wanted to thank you guys again for inviting me as a community partner. And if anyone is interested in following up with CIATS or seeing what we're up to or when we'll be reopening to regular programs, you can follow us on Facebook, and then all of our contact information is on there as well. Thank you.
Sarah, thank you so much for the presentation and the information. This has just been fabulous. I have learned so much about what we're doing and just all of our great community partners that are out there. So 2 quick things, and then actually, Alex, if you want to take the slides down for a minute, that would be great. What I wanted to do is just give you a quick closing, and then don't worry, we are getting to giveaways, because who doesn't love a giveaway at the end of a conference? So we are definitely going to make sure that we get to that very quickly. So hopefully we are on track here. Alex, we're all set. You can see my screen now.
Yes, good to go.
Perfect. All right. So what I just wanted to do in closing is that please complete the survey. The link was put into the chat. Share the care, and that team would love to get your feedback. But I will also say there are some fabulous prizes, including a stay and play package that was donated by Red Cliff Community Health Center at the legendary Waters Resort and Casino. So there are just wonderful things. So please, we have loved your participation and would love your feedback. So I also want to give a big thank you and shout out to all of our speakers. Fabulous information. Thank you so much for sharing Share the Care with us, planning committee, and the biggest thanks and shout out to Carol Cameron. Your not only what you have done for today, but just your dedication and passion to support Share the Care effort over all these years. You know, you're a pretty special person, Carol, so thank you for all of that. And Carol wants to make sure everybody knows that the hope is to bring this back in person safely in 2022. So please, I will say, mark your calendar that we will all be back together shortly in just the next year. So let us share. I want to share 2 things just on behalf of the collaborative. We're going to send this out in a follow-up email, but there are resources available, not just from us, but from our community partners on COVID and cancer. If you've heard some things today that have inspired you and said, I would love to do more, what can I do? There is some information online. And then also we want to invite you to join us for the Wisconsin Cancer Summit that will be held virtually October 20th and 21st. So again, we will send all of this in a follow-up email, but just wanted to share that with you. And with that, we're going to get to the virtual Spin It to Win It with Janelle Elza. So I'm going to stop sharing, Janelle, and I'm going to turn it over to you. So
So in many Native American traditions, there's a beautiful practice called the giveaway, where one gives something away to honor the person or the space. So in true Share the Care fashion, we have some prizes to spin and win. And then that evaluate. So I'm going to do 3 prizes. There's 2 pairs of beaded earrings and a beaded pop socket. I'll put the picture in the chat in a minute. I meant to do that. I'm sorry. And then there's if you do the evaluation, there's the stay and play package, and Carol has like 12 other prizes for that as well. So let's see, I'm going to share my screen. Okay, let's see. So I'm going to spin her 3 times. Let's see, here we go. Can you see it? Okay. All right, so I'm going to write that down. Jolene Ganson, way to go. So I'm going to remove her name, give her another spin. That'll be for a pair of earrings. This will be for the other pair of earrings. Amy. All right.
Janelle, I think we do this even in person. This is so fun. Maybe it'll be a big wheel.
And then lastly, the pop socket. Here we go. And this is from the Red Cliff Community Support Group. So thank you so much. Jalissa, congratulations, everybody. And thank you so much for attending. Again, thank you to Carol Cameron and Beth Brenner, the Wisconsin Cancer Council, for everything that you have done to help us out. Hannah Foley, Alex, Beth, Tina, thank you. I appreciate everything.
Excellent presentation. Loved every second of it. Thank you so much.
Well, thank you. So just in closing, in true Share the Care fashion, we want to just take a moment as we close out today. So thank you, Janelle. Thank you, Carol. Thank you to everybody. Thank you to all of our presenters. Just as we close, we're going to end today just keeping in our thoughts those of us that have experienced a cancer diagnosis, and really hold in our hearts the memories of our loved ones that we have lost to cancer. So we're just going to play some music and end our day today. So thank you again. Look for our email to come, and thank you again.